Welcome everyone, I hope you've had an amazing week. This is GP Made Easy and I'm Dr. Daniel Follows, a fully qualified GP living and working in the UK. So today I'm going to cover COPD as it is a common condition in the UK and has a high mortality rate. And recently there have been some updates in the guidance, so hopefully you'll be able to understand it more after this video. But before we go into this, don't forget to like, comment and subscribe. It lets me know that you're enjoying this content and I'll make more videos. So let's dive in. First of all, a little bit of background about COPD. It is defined as persistent respiratory symptoms with airflow limitation. It is the third commonest cause of death worldwide, and it is estimated that about 3 million people in the UK have COPD, but only 1 million actually have an official diagnosis. Risk factors include smoking, occupational fumes, dust particles, and air pollution, so make sure you cover all of these when taking a history. And in a subgroup of COPD patients, it's caused by a genetic condition called alpha-1 antitrypsin deficiency. So, how might someone with COPD present? Well, the symptoms include progressive shortness of breath, a chronic cough that can be productive of sputum, they may have wheeze, and as stated earlier, they may or may not have had exposure to the risk factors mentioned earlier. With the history, don't forget to ask about diurnal variation, as some patients can have COPD with asthma. And don't be alarmed if respiratory exam is normal, as that can be the case with these type of patients. So to diagnose COPD, you need to get a spirometry test. And other tests you can consider is a chest x-ray, if you think there may be other conditions causing it, such as heart failure, and also a full blood count to check for signs of secondary polycythemia. And it's also good to get the eosinophil count, as you'll see later on it will help with management of these patients. So you diagnose someone as COPD if they have symptoms and their spirometry shows an FEV1 over FVC less than 0.7. So once you've diagnosed someone with COPD, there are many different grading tools to rank the severity of their COPD. So the most classic one that we're known with from med school is this one up here, which is based on their FEV1. And so as you can see, there's different gradings from mild, moderate, severe to very severe based on their FEV1. So mild is when it's greater than their predicted. Moderate is when it's less than their predicted but greater than 50%. Severe is when it's less than 50% but greater than 30%, and very severe is when it's less than 30%. The next type of grading system that I've got up here now is called the MRC dyspnea scale, and it gives a patient a grade based on how breathless they get. So as you can see, where it's like the very severe, they can't even leave the house because they're so breathless, whereas the lower grades, they can go bit of a distance before getting short of breath. Another type of grading system is the CAT questionnaire, which you can see is up here, and it has a variety of symptoms that it screens patients for and gives them a total score at the end. And then the final type of grading is called the ABE. So as you can see, you can use either the MRC or the CAT scoring for it, and it ranks patients into a group based on those scores and how many exacerbations they've had over the last year. And this is the one that GOLD tends to use, as you'll see shortly. It helps us decide which treatment to give patients. And the World Health Organization recommends that every COPD patient gets screened for alpha-1 antitrypsin deficiency, but this isn't in the NICE or GOLD guidance. Now, on to the management of COPD. First of all, you can see up on the screen, I've got a little pyramid, and this shows certain interventions for COPD, and it has the cost per quality adjusted life year shown in the pyramid. And as you can see, the two cheapest interventions are vaccination and smoking cessation. So it is recommended that for all COPD patients, they're offered the pneumococcal vaccine and the annual flu vaccine. And then the next step is to discuss smoking cessation with them. So next up, I've got a table up here, and it shows how their FEV1 deteriorates over time based on if they quit smoking, if they have intermittent gaps of quitting smoking, and if they continue smoking. And as you can see, the continuous smoking has the most rapid decline in FEV1. In some practices, you may also have access to a carbon monoxide monitor, and you can use this to try and educate the patient to show them the importance of smoking cessation as well. You can also discuss the nicotine replacement therapy with them as well, the medications, but for most areas now this is done by local resources. So for example, in the Walsall area we give them a self-referral to Be Well Walsall that does all of that side of things. And then next step for all patients is you would offer them pulmonary rehabilitation, and this is where they're given physical exercises to help improve their lung capacity, and they're also educated more on COPD. And it's actually been shown that pulmonary rehabilitation helps improve shortness of breath, health status and exercise tolerance. And then next we move on to the inhalers. So I've got another diagram up here, and it's based on their ABE grouping that we discussed earlier, and based on which group they end up in, they'll either have a LABA, a LAMA, a combination of a LABA and LAMA, or even triple therapy of a LABA, LAMA and inhaled corticosteroid. And you can see from the table that depends on their eosinophil count. That's why it's helpful to get a full blood count when initially investigating them. And this table is used both in the NICE and GOLD guidance. And then the next table I've got up here shows when you would escalate treatment. So number one, if they come with just worsening breathlessness, you would go down the table, but if they're already on a LABA and LAMA, then it's suggesting to look for alternate causes of their breathing problems. The next side of the diagram shows that if they present with an exacerbation, then you escalate the treatment based on their eosinophil count, as you can see. And if they're still deteriorating, then things to consider are prophylactic antibiotics or roflumilast, but both these treatments are initiated by secondary care. So at that point, if you were considering them, you would need to refer the patient to see the respiratory consultant. It is also recommended that patients with COPD should have a rescue pack of antibiotics and steroids at home and clearly educated on when to use those. And then I've got a diagram up here where in some patients there may become a point where the inhaled corticosteroid isn't actually beneficial for them and you may need to wean them off it. So just have a look for yourselves. Please check your local formulary for which inhalers are available for your COPD patients, and it's recommended if you can to have all components in a combined inhaler. I'll also put the link up here if you haven't watched it already for my video on inhaler techniques, so you can go over that with the patient as well. With any of the inhalers, you can also give them a SABA to use as and when they need it. In certain patients, if their COPD gets very severe, they may need to go on home oxygen, and it's recommended to refer patients for it if they have oxygen saturations less than 92%, if they have a FEV1 less than 30%, if they have cyanosis, or if they have secondary polycythemia, if they have peripheral edema, or there's signs of a raised JVP. When patients reach end-stage COPD, there are other treatments that can be given to help with symptom control. For example, for breathlessness, you can give opiates or neuromuscular electrical stimulation, chest wall vibrations, or they can even use a fan to help. If they're having increased mucus production, you can give them carbamazepine or N-acetylcysteine. And if they're malnourished, you can give food supplements, which we'll cover in more detail shortly. Moving on to acute exacerbations of COPD. This is defined as a sudden onset increase in breathlessness, mucus production, cough or wheeze. And when you've assessed the patient, if you're concerned that they're systemically unwell, then you get them admitted to hospital. If a patient is safe enough to be managed in the community, then first of all you would recommend them to increase the use of their SABA for symptoms, and then next you'd give them a short course of steroids. So we normally tend to give prednisolone 30 milligrams for 5 days. It's recommended that if they're needing 3 to 4 courses of steroids per year, then consider the need to add on bone protection for these patients. And then next, if they have got signs of infective symptoms, then you can add on antibiotics. The first line antibiotics we tend to give are amoxicillin or clarithromycin or doxycycline. And it's recommended that if they've made no improvement in 2 to 3 days, then to call back, and at that point you'd send a sputum sample off and consider changing them to an alternative antibiotic. You can use a different one from the first lines I've just mentioned previously. For patients who have high risk of treatment failure, for example if they're needing frequent antibiotics, if they've had a sputum sample currently or in the past that has shown multi-resistance, or if there's an increase in complications, it is recommended to give them coamoxiclav, the 500/125 dose 3 times a day for 5 days, or cotrimoxazole 960 milligrams twice a day for 5 days. It is recommended in any exacerbation of COPD to follow them up in 6 weeks to review their treatments to see if their inhalers need escalating. And it's recommended if they're having 3 or more exacerbations per year, then to look into if there are any other conditions that could be causing this. Now, moving on to nutrition, it's recommended to address this as poor nutrition can lead to increased mortality, and especially malnutrition predisposes them to infections, decreased respiratory effort, decreased exercise tolerance, and decreased quality of life. So it's recommended for these patients to do a MUST score, and I've got the diagram up here of the criteria to do for a MUST score assessment, and based on the score what it's recommended for nutritional support. And it's recommended to do this at diagnosis and at every annual review. It is also recommended as part of the assessment to check their mood, as low mood can lead to decreased appetite and them not wanting to eat. And then as you can see based on the score, there's either just to reassure them and check it again, if you give them some dietary support, or if they need to go on nutritional supplements. So dietary support normally involves bulking up certain parts of their meals, and I've got the diet sheet up here, one that I give to patients, and I will link it down below. If a patient needs to go on supplements, then it's recommended that they go on it twice a day, and you can give them a flavour not specified pack first to see which ones they like, and then just aim to prescribe the flavours that they like. And then it's recommended after you've started it in 6 weeks' time to check their adherence to the supplements. Well, that's it for today's video. I hope you found it helpful and learned something new. As mentioned earlier, I'll link all the NICE guidance, the GOLD guidance, and all the resources I've recommended in the description below. Don't forget to like, comment and subscribe. It lets me know that you're enjoying this content, and I'll keep making more for you. And if there are any topics you would like me to cover, then please comment down below and I'll pick them up and cover them in later videos. I'm also on Instagram, if you want to check me out on there. It's up here, it's the same name, it's GP Made Easy. Or if you would prefer a different way to get in touch with me, you can also email me, and my email address is just up here. Well, I hope you guys have an amazing week, and I will see you in the next video.